Hello, all. Welcome to our inaugural Female Athlete Research Forum featuring Dr. Ella Smith on monitoring hormones in female athletes, best practices for designing and interpreting research. Thank you all so much for joining us today. My name is Hannah O'Day, and I'm a researcher with the WUSI Human Performance Alliance, and I'll be moderating our forum today. This forum is hosted by the WUSI Human Performance Alliance. The Alliance is a nationwide alliance of 7 institutions, including Stanford University, Emory University, the Salk Institute, the University of California at San Diego, the University of Kansas, the University of Oregon, and the Women's Health, Sports, and Performance Institute. The Alliance's mission is a super exciting one. It's to transform human health through the science of peak performance, and we're committed to discovering the biological principles that optimize human performance and can catalyze innovation in human health for all. One really exciting and compelling initiative within the Alliance is our Female Athlete Program, where our mission is to elevate the health and performance for female athletes through data, research, and education. We have a postdoctoral fellowship in female athlete research, and Dr. Carly Jones, who's on the call, is one of our inaugural fellows. So I'll hand it over to her to introduce herself and the vision behind this event.
Thank you, Hannah. I'm a biomedical engineer, and I use advanced MRI techniques to better understand the relationship between muscle physiology and the menstrual cycle. It has been so amazing to see the increase in awareness and interest in understanding female athlete health and performance among many different groups, from athletes and sports investors to the media and researchers. The idea of the Female Athlete Research Forum arose from our journal club, where we are exploring the latest research in female athlete performance and best practices for conducting research. We wanted to share what we are learning and also tap into the greater community's expertise so that together we are all elevating the scientific evidence around female health and performance. Please reach out after this forum if you'd like to join our regular journal club discussions.
So before we start, I'm going to review the forum format. We'll begin with a 25-minute research presentation from Dr. Smith and follow that with a Q&A. And we've been really excited to build community within female athlete research. We've got athletes, coaches, students, researchers, clinicians, all on this call from around the world. And we really welcome you to share your questions and your expertise. So please use the Q&A panel at the bottom of your screen to enter your questions. I think you'll be able to see this on the slide, an example of what this panel looks like. And in the spirit of building community, we'll also give you the option to be promoted as a guest panelist to join us here and verbally ask your question and or turn on your camera if you're comfortable. And so please indicate that you'd like to be a guest panelist by adding 3 asterisks before your question. As a default, we'll read aloud your question if you don't indicate with those 3 asterisks. And please note that this event is being recorded. It will be shared publicly, so please do not make your own recording, transcript, or use AI-generated note takers on the call. We'll remind you of those ground rules at the end of the meeting as well. So without further ado, I'd like to introduce Dr. Ella Smith. Dr. Smith is a sports physiologist at the South Australian Sports Institute, and she completed her PhD with Louise Burke at the Australian Catholic University, studying female-specific physiology, including conducting research on hormonal fluctuations, energy availability, and competition performance. Following her PhD, Dr. Smith transitioned to the role she's in now, where she is applying that research to guide training and recovery for female athlete health and performance in high-performance environments. We're really excited to hear from you, Dr. Smith. Please feel free to enter questions in the Q&A while Dr. Smith presents, and then we'll take them after the presentation. The chat moderator also added a cheat sheet to the chat with some useful terminology that you can use to follow along, and the chat moderator will continue to add some links that Ella presents in her talk as well to the chat. So without further ado, Ella, I'll hand it over to you to share your presentation. Thanks so much for joining us today.
Awesome. Thank you so much, Hannah. Thank you for the introduction and thanks for the invitation to this webinar today. A quick note before we start on language. So wherever possible, I'll try and use the term female athletes for sex-based physiology and women for any gendered or structural term. So treating sex and gender as distinct variables and recognizing that the two don't always overlap. And this paper that I'm going to talk through today focuses on ovarian hormonal profiles specifically rather than sex or gender. So today I'm going to talk through this paper here, which is a combination of the learnings from my PhD research. So I started my PhD slightly outraged by how little high quality research was out there in women, and I was super excited to add to the evidence base. But I definitely didn't appreciate just how challenging it would be to conduct gold standard research to classify and control ovarian hormone status in the applied sports science setting. So this paper here brings together our experiences of conducting high quality research in women, and it provides some practical tools and resources based on our learnings to aid other researchers and hopefully making conducting research in women a bit less daunting. And at the same time, understanding these guidelines will also help when you're trying to interpret existing research with regards to how ovarian hormone status is classified and how the results can then be interpreted and applied. So I wanted to start by talking a little bit about some of the problems we have with existing research and the kind of messaging that exists on social media in this area. So there's a lot of content online suggesting that we need to tailor our training and nutrition around the menstrual or hormonal contraceptive cycle. And as with a lot of things here, social media is way ahead of the scientific evidence. So the graphics that are on screen right now present the idea of cycle syncing, which is the idea that we need to we need to schedule our training and nutrition around the menstrual cycle. And we don't have any scientific evidence to support that this is necessary. So what I mean by that is that if I walked into a room full of women, I couldn't prospectively prescribe their training according to their cycle without knowing anything about them. So training studies are very hard and long to conduct. Until my knowledge, there haven't been any done investigating specifically altering training and nutrition around the menstrual cycle and measuring subsequent adaptation. What we do have is evidence that performance itself doesn't appear to be altered across the menstrual or contraceptive cycle, but in terms of training, the evidence just isn't there yet. I'm not saying it might not appear in the future, but for where we are right now, these graphics are way ahead of the evidence. So the point of this slide was just to illustrate that the studies that might have made these conclusions are typically poorly conducted with regards to how they classify and control ovarian hormone profiles of their participants. And it's super important to understand these methods so that we can appropriately interpret the findings. So the growth of women's sport over the last few years or decades has led to more studies that investigate women, which is awesome. However, many of these studies use assumed or estimated phases to characterize ovarian hormone profiles rather than directly measuring key characteristics such as estrogen or progesterone concentration or ovulation. So an estimation is essentially an educated guess. And the figure here from this paper by Kirsty illustrates that perfectly. So the purple at the top is an idealized 28-day cycle, which is what estimations are typically based off. And straight away you can see in blue just some of the other possible cycle characteristics that we can see, which clearly don't align with the purple. So for example, the arrow on this x-axis indicates ovulation, which by default is estimated by menstrual cycle tracking apps to occur on day 14, which is halfway in that ideal 28-day cycle. But you can see that the actual day varies across all the different cycles in blue. So in studies where I've actually measured this myself, I've seen that ovulation has actually ranged from day 10 to day 21. So if I estimated day 14 for everyone, I would have been completely missing true ovulation in the majority of participants. And in another study that I did, only 11% of our 40 participants had the kind of ideal 28-day cycle. So if I'd used this estimation in this study, I would have actually missed ovulation in 89% of my participants. And these errors persist across all the cycle phases. So if we tried to estimate phase 4, which is where we see high estrogen and progesterone, In the long cycle, we again would miss this because we're too early and we end up missing the desired phase. So by guessing, we therefore can't draw conclusions regarding any influence of ovarian hormone status on an outcome measure such as performance. So there's numerous papers out there that have been developed that provide detailed guidelines for classifying and controlling ovarian hormone status. So I'm not going to talk through the detailed methods of those today, but what I am going to focus on is the practical application of these guidelines in applied research. So we're not denying that implementing high quality and rigorous methods to classify and control the ovarian hormone status of female participants in research is challenging. It requires more time from the participants, more funding, and more resources, and it can be particularly challenging in the applied setting when athlete time is limited. So the paper I'm going to talk through today aims to make it easier to conduct high quality research in women. So the main part of the paper is this tiering system that ranks the methods of classifying and controlling ovarian hormone status as gold, silver, bronze, or ungraded. And this system can be used both by researchers and also those reading papers to better understand how to interpret the findings. And then the second part of the paper outlines practical study design tools and resources to implement the tiering system. And these resources are based on our experiences of implementing these guidelines in the applied setting. So firstly, I'm going to start by talking through the tiering system. And we actually developed this based on those best practice guidelines that I mentioned earlier. And this was developed with Kirsty Elliott-Sale, who is an author on these papers. So as I said, this system ranks the methods of classifying and controlling ovarian hormone status as either gold, silver, bronze, or ungraded. So we can use this tool both retrospectively to evaluate existing studies and also prospectively to guide the design of future research. And the basic premise of the system is that gold standard includes everything you need for full understanding of an individual's ovarian hormone status. But when we were developing this framework, we also wanted to include silver and bronze tiers as alternatives, recognizing that high quality research is still achievable at these levels if the strengths and limitations are transparently presented. So the silver and bronze tiers include less methodological rigor, but come with some limitations in how you can interpret those findings. So I just wanted to highlight that this tiering system reflects the quality of the classification and control of ovarian hormone status only, and not the overall study quality in general. So it can still be a great study, but knowing how the ovarian hormone status was classified is important when we try to interpret these findings in relation to women. So there's three key methodological aspects to consider when you're going through and looking to apply the tiers. And I'm going to talk through each one of these criteria in more detail in the next slides. And I also wanted to highlight that for ease of viewing, I've combined both those methods for people using contraception and those not into a single podium. But it's important to note that this system is implemented separately for individuals who use contraception compared to those who don't, even within the same study. So firstly, cycle tracking. So in those who don't use contraception and are naturally cycling, this refers to calendar counting of the cycle. And then in those who use contraception, this refers to the tracking of the withdrawal bleed and the active or inactive pill days for those who take an oral contraceptive pill. And what differentiates the tiers here is the length of the tracking. So gold tier tracks more than 2 cycles, so minimum of 3. Silver tier tracks 2 and bronze just tracks the 1. So when we consider those who don't take contraception specifically, we also need to consider a screening versus a measurement menstrual cycle. So a screening cycle establishes our menstrual cycle characteristics, whereas the measurement cycle is where we look to assess our outcome measures. So we can achieve gold tier through a various different combinations of screening and measurement cycles, provided at least 3 consecutive cycles are tracked. So I've put a few options up here. So you can see that the first option achieves this just by tracking 3 cycles. So the second one acts as both screening and measurement. And then the other three options there involve 4 cycles that are tracked. And you can pick the option that best suits the logistics and the study design. So you can see that we always start with an initial screening cycle, so that one in green. And this is required to establish the menstrual cycle characteristics. And the second cycle is then required to confirm these. And often you're using that first screening cycle as part of participant recruitment to see if individuals meet your desired profile for the study. So, for example, if you're looking to recruit eumenoric women only, we need to first assess and verify this. And then when we look at the pink measurement cycles, we need to duplicate our measurement cycle to verify the outcome measure, given the known inter-individual variability in menstrual cycle characteristics, which is again why there's always at least 2 measurement cycles. And again, this is just for the gold tier. So moving on to hormonal measures. So these refer to measures in blood and ovulation. So when we look at the gold tier, this is taking blood samples for endogenous hormones, so estrogen and progesterone, plus measuring ovulation for full biological verification of hormonal status. When we look at silver, this measures ovulation only, without any blood measures. And then bronze doesn't actually have any direct biological verification of the hormones. And it's suggested that this is also done in those who use contraception, as firstly, not all types of hormonal contraception inhibit ovulation. And it's also useful to understand the endogenous hormonal profile of those who take contraception, and it's still informative in verifying their hormonal status. So moving on to contraceptive use, and this is reported for both those who use contraception and those participants who don't in your study. So the participants that don't, we still need to document the history of prior contraceptive use. And the recency of use is what determines the tier. So to be gold, they need to have not been taking contraception for at least 3 months before they start the study. And then in the silver and bronze tiers, this is either less than 3 months or not stated. And then if we move on to those individuals who do use contraception, there's 3 different things to consider in terms of your reporting, and the level of detail in your reporting is what determines the tier. So the first thing is the contraceptive type. So whether that's an oral contraceptive pill, an implant, an injection. Second is the formulation. So this is the name and concentration of the exogenous hormones. And then the third one is the length of use. So we want our contraceptive users to have been taking this for at least 3 months before they start the study. So the next part of the system isn't a specific method in itself, but it's more how participants are grouped within the study and the uniformity of the participant cohort with respect to their hormonal status as a result of kind of the methods you've done previously. So a gold tier would have all participants, sorry, I'll start with contraceptive users, I should say. So if we think about contraceptive users, the gold tier, they'd all be taking the same type and formulation of contraception. So for example, they'd all be on the same pill with exactly the same profile. And then silver and bronze would be a mixture of contraceptive types. So you'd have a bit more hormonal variability in there. And then if we go to consider those who don't take contraception, so naturally cycling, the gold standard would be all with the same menstrual status. So for example, they'd all be eumenoric. And then silver and bronze would be a mixture of menstrual statuses. And noting that in the bronze tier, we'd also have some unknowns due to having less rigorous previous measures. So for example, we wouldn't be able to identify an ovulation because ovulation isn't measured in the bronze tier. So lastly, if we think back to the very first tiering slide, so the ovarian hormone status is the outcome of all these methods that are applied throughout the tiers. So if we've applied a gold tier, this allows for full identification of ovarian hormone status. So in those who are naturally cycling, we'd be able to identify all menstrual cycle phases, irregularities, and any asymptomatic irregularities as well, such as anovulation. And for those that take contraception, the gold tier, we would know the type, formulation, brand, length of usage. And then the detail of the information you know about the ovarian hormone status reduces as you go down those tiers. And ultimately, this influences how the findings can be applied. So I'm going to discuss a little bit now how to choose a tier with recognition to the cost and benefit of each. So obviously we'd all like to apply gold tier all the time as it provides the highest internal validity, but we wanted to recognize that this is also resource intensive as is highlighted in the table on the screen. And I really wanted to highlight today that a study can still have a high quality approach if the methods are transparently reported so that we can interpret them appropriately. So, for example, if you didn't measure ovulation in a study, state that in the methods that ovulation was not measured rather than just omitting the information entirely. And this allows others to better interpret and apply the results. So, in terms of which tier to choose, the appropriate tier should be determined according to the individual study. So the tier you pick is going to determine the internal validity and generalizability of your findings, and also the depth of hormonal information that you have. So this in turn informs the conclusions that we can draw, and therefore the choice of tier must align with the research aims, as well as taking into account practical constraints. So the first thing to consider is your research question. So if the study is directly looking to examine the influence of ovarian hormones on a particular outcome measure, then we need to do the gold standard. So if you're looking at the influence of menstrual cycle phase on running performance or VO2 max, then we have to use gold as this is the only tier that's able to identify menstrual cycle phases, and that's your independent variable. And also, if you have a study where your dependent variable is known to be influenced by ovarian hormones, we also need these higher tiers. However, on the contrary, if you're conducting maybe an observational study on people's dietary habits, a bronze tier without any detailed hormonal measures might be appropriate for this. So we recognize that gold tier is more time and resource intensive, which has to be a consideration in terms of your resources. So for example, if you do an initial sample size calc, and this shows that you're going to need hundreds of participants for your particular study, it's likely going to be pretty challenging to recruit the required number of individuals, all with a uniform menstrual or contraceptive status, as you would require for gold tier. And in such instances, a lower tier might be appropriate as long as the reporting is transparent. And at a minimum, I would recommend that all studies achieve a bronze tier, even if you don't perceive ovarian hormones to be directly relevant to the outcome measure, as there's no costs or resource really demands on implementing the bronze tier, which I'll talk through in the next slide. So one key aspect of this paper provides resources to help researchers actually implement the tiering system. And these resources were developed from the learnings across my PhD studies. So the first is basically just a nice checklist of everything you need to consider when you're planning a study and also the information that needs to be included in the manuscript methods. So again, I wanted to really highlight that transparent reporting aspect. So even if you haven't measured a particular aspect on this checklist, so maybe you haven't measured endogenous hormones, it still needs to be stated that these weren't measured, as this is going to help us to interpret the results appropriately rather than just omitting the information. So secondly is a flowchart. So this can be used when planning studies to decide which tier you might select. And it highlights the necessary steps for each tier, and it's intended as a bit of a decision-making process to help guide researchers through. And lastly, we also have a participant pre-screening questionnaire, which allows you to partially identify participant ovarian hormone status. So when participants complete this questionnaire, this actually provides sufficient information to achieve silver tier for those that use contraception or bronze tier for those that don't. And we've also provided a user guide as well to help researchers in interpreting the responses. So we've tried to make it as easy as possible in this paper to achieve the bronze standard. So just by your participants completing this questionnaire, you already have that information. And again, the key message is that transparent reporting is a high quality approach. You don't always need to hit the gold tier. if a bronze was appropriate for your study design, that's fine, as long as the methods are clear. So most of the studies in my PhD actually didn't quite achieve the gold tier. We did silver plus the addition of blood hormone measures. So we had everything in the gold tier, but what we weren't able to do is complete a second measurement cycle as is required. Because of the logistics of doing a training camp with elite athletes, we simply couldn't double the length of the training camp to take that second cycle measurement as was required. But it was still a high quality study because this was reported and all the detail was provided. So just to finish up, a few take homes. So started with how to cautiously interpret existing research. So being mindful of how research has actually classified and controlled ovarian hormone status. Then provided tools to conduct high quality classification and control of ovarian hormone status. So our tiering system, and then also those resources to help you implement it. And finally, as I said a few times today, transparent reporting is the absolute key. So whatever you do, just report it in the methods, and then this helps everybody in interpreting the findings appropriately. So that's all from me for this part of the forum. Thank you so much for everyone who's listening. And yeah, I'm really excited to dive into some questions. So I'll hand back to Hannah.
Woo! Great job, Ella. Thank you. That was such an informative talk and so many practical examples and resources that our chat moderator has put into the chat. So feel free to take a look through those and use them to seed our Q&A. I'm really excited to start this, open this. We've already got some questions. Just a reminder of how we're going to use the Q&A. As a default, we'll read your question aloud. But to build community within our female athlete research community, we really invite you to join as a guest panelist, verbally ask your question, introduce yourself, and turn on your camera if you're comfortable. And so just a reminder of how this will work. When we're ready for you to ask your question, we'll make you a panelist. And then a pop-up that looks like this will come up on your screen asking you to join as a panelist. And after you hit accept, there'll be a slight delay, and then you'll re-enter the meeting as a panelist. So you'll be able to turn your camera and microphone on to ask your question. And so if you'd like to do this and join us up here, please indicate this by adding 3 asterisks before your question as shown in that pop-up there. And as I said, I think we've already got some questions in the Q&A. So we're going to promote those folks. I think there's a few with some asterisks to go on camera, join us as a panelist. First up, we have Sela Salzman. We are going to promote you now as a panelist, so feel free to accept the invitation and you can turn your microphone on and camera. Introduce yourself, Sela, and ask your question. Thanks so much.
Sweet. Thanks, Hannah. Hi, everyone. I'm Sela. I'm over at UCSD. Thank you, Ella, for this awesome presentation. It was super informative, and honestly, it's great for me to be able to look back and use this tier system when looking at and interpreting previous research. But with that, when it comes to moving forward, how can researchers include but also adequately account for naturally menstruating individuals who don't fit a eumenoric profile?
I was on mute, sorry. No, that's such a good question, and it's something that's super applicable because we know that that kind of eumenoric cycle actually isn't that prevalent. So that idea, especially an idealized 28-day cycle, particularly within athlete cohorts, menstrual irregularities are even more common, and the athlete cohort is where I kind of focus my research. So this is kind of your question kind of reflects my PhD journey almost. Like the very first study was very highly controlled. We tried to have a super uniform hormonal profile and discovered how challenging that was. Although it gave us great information, it was super challenging. So then as I moved through my PhD, our final study, we decided to be a bit more varied with our profiles. So we actually allowed anyone who wasn't on contraception in because we were looking at the effect of the ovarian hormones. So anyone was able to join. They still did all the blood hormone measures, ovulation measures, so that we could have a full understanding. And then we just comprehensively reported each participants' ovarian status according to the checklist that was given there. So average cycle length, we reported if they ovulated or not, and this was checked across at least 2 cycles, length of prior contraceptive use, and then we were able to use those participants accordingly within the particular research question. So we only use those participants, for example, who showed a surge in estrogen and a surge in progesterone if we were going to look at those measures, if that makes sense. So yeah, that final one was more inclusive because of how hard it was. But yeah, I would just encourage to use that tiering system because it then gives you the information and then you can kind of decide based on your study who you will and won't include. But yeah, I definitely have moved towards trying to be a bit more inclusive and broad in that scope, just so it's more generalizable as to our population. But yeah, again, just reporting what we've done so that we actually know that that's the case rather than just saying 20 naturally menstruating individuals and that's kind of it. Like, there's so much more to
Yeah,
it than that.
definitely. I feel like that comes with the transparent reporting, like you were kind of hammering on at the end, especially because there are so many athletes with such varying cycles that are, reoccurring every month or every 2 months.
Mm.
So that's really helpful. Thank you.
Thanks, Sela, so much. All right, next up, we've got Emily Kraus. Invite you to turn on your camera, unmute, introduce yourself, and ask your question.
Dr. Ella Smith, you did such a fantastic job covering a fairly complicated, challenging topic in a short amount of time. The figures were excellent as well, so those figures will be very helpful for many. So I'm Emily Krause. I'm the director of the Stanford FASTER program, which is part of the WUSI Human Performance Alliance. And my question is around how you apply this to different populations, from the adolescent athlete who might have more menstrual cycle variability, or the postpartum athlete who might not have a menstrual cycle yet. And I'm sure it's fairly nuanced and complicated, but specifically for the adolescent athlete, have there been studies that have looked at ovarian status in this group with this type of testing in models?
I mean, yeah, thank you so much for your question. And yeah, it is super nuanced. Like, even within the population that isn't adolescent or perimenopausal, there's still variability. So then when we introduce like adolescence, perimenopause, menopause, it's just, yeah, there's a whole heap of variability. But again, I just go back to, yeah, using the tiering system because you never know what you're going to find until you've actually measured it. So going back to
Right.
Kirsty's measure rather than estimate, like we may have maybe a 16-year-old athlete, we might just assume that they're not going to have cycle regularity. But actually, we do the questionnaire, we found that their age of menarche was 10 and they've had a regular cycle for like 5 years. So they actually are eligible for our study. We wouldn't have known this without having actually measured that and asked them that and verified their ovulation status. But equally, we might have another 16-year-old who age of menarche was only 15. So their cycle is super irregular. So therefore, they might not be eligible for this study, maybe a different study. But we wouldn't have known that if we hadn't actually measured and found out that information. I hope that answers your question.
Yeah, thank you. Great examples.
Thanks, Emily. We'll just add on a question from the chat, from the Q&A that isn't someone that's going to go on camera, so I'll just read it aloud. Clay Bullwinkle says, is your study only for adults? Have you included in your study less physically mature females and classified results according to degree of physical maturity? So that sort of relates to Paul's on.
Yeah.
Yeah.
Yeah. No, all the studies that I've done have been in adults. So between 18 and I think the oldest I had was 40, because I was specifically interested in the ovarian hormone fluctuations across the menstrual cycle. So I wanted to make sure that, yeah, our athletes had a sufficient age post-menarche to have a regular cycle. And then in terms of including those older adults, I didn't put an age cap on it per se. I just wanted to make sure they weren't in perimenopause. So again, I won't know by someone's age whether that's the case. So if an older individual was interested in participating, so anyone kind of over 35, that was still fine. I just did the same methods as for everybody else. So ovulation testing and blood hormone measures. If they still had a regular cycle, were still ovulating, there's no indication that there's any sort of menopause going on. So happy to have them involved. Yeah, menopause and perimenopause is outside of my area of expertise. And it's not something I've really looked at, but I would definitely say you can still apply this system because you still need to know the same information. So I definitely say it can be applied across the different scope of ages. But yeah, in terms of the direct outcomes, it's a bit outside of what I've looked at.
super helpful. And I think, yeah, thinking about, the pre-adolescence and also after menopause, I think that addresses a little bit of another question in the chat that or from Rochelle Pajednik, that I'll just say aloud, I think also in that scope. Um, Anything you'd like to add, Rochelle?
Hi, sorry. I thank you so much for the question. Actually, Ella, my question was specifically about women in perimenopause, and I know that you said that there's an area of expertise there that you don't necessarily have. But as we think about how to expand this framework, particularly thinking about women that are cycling differently or in this very sort of tumultuous hormonal phase within that sort of, 35 to 50-year-old age range. Do you think that this tiered system would in fact apply to that group? And how would you potentially change things in order to better capture that data in this particular group of women?
Yeah, no, that's a great question, and it's something I would love to know more about, and we definitely need more research in that area for sure. I think my kind of gut answer is that we'd still want to be applying the system because we still need that information, right? But say, for example, we find that we're interested in individuals in perimenopause, and we find that they're not ovulating or they have irregular ovulation or the cycles are somewhat irregular. That's still important information in that context. So I wouldn't say that we would change the tiering system per se, but maybe the requirements would be different in terms of your eligibility, if that makes sense. So maybe you don't need 21 to 35 days because you're not looking at amenorrhea, you're looking at something else, but you still need that same information, if that makes sense.
Yeah, for sure. And just to follow up on that really quickly, do you think that a longer time period might be more beneficial for this particular group of women for the monitoring, or do you think that they're the time periods that you've outlined already would potentially apply?
I mean, longer's always better. Like the more information you can have for sure. Like I think of an example of one study I did. Again, I included this individual, but she had a cycle length of over 40 days, and we just didn't have time to capture enough cycles. We just did what we could. So like the longer the better, because we know that even from one cycle to the next, you can have so many fluctuations. So ideally, we'd have like a heap of cycles, but we've put two in as the kind of bare minimum. So one to identify what your characteristics are, and then the second verifies it. Ideally, we'd have third, fourth, fifth, and if you can facilitate that, that's awesome. But kind of two we've put as the minimum for that reason.
Great, thank you.
Thanks, Rachel. All right, next up, we've got Stephanie Cohn. Go for it.
Hey, thank you. So I'm Stephanie Cohn. I'm at University of Delaware in biomedical engineering as faculty. And I was super excited to see all of these topics. And I think a lot of what we've been doing internally is really well aligned. We've also settled on we're going with 3 cycles as kind of our bare minimum if we want like well set, consistent data. My question is related to something we're running into right now with analyzing all of this like daily biomarker data. We're realizing that it feels almost like we're trying to shoehorn into cycle phases that were named based off of different rules. So when we look across the papers, it's like, okay, are you dividing in even quarters? Are you dividing at ovulation? And I guess my question is, what are kind of some thoughts on the value of actually calling things into 2 or 4 distinct cycle phases versus just kind of defaulting out to saying if we have hormone data, then, maybe we present the cycle in order, but should we be trying to fit to phases or should we just be reporting daily data where it's available?
Yeah, that's such a good question. And that's something I came across as well while doing
Mhm.
research. So yeah, that's actually exactly the reason behind one of the approaches I took. So again, one of the first studies in my PhD was very highly controlled. We were trying to identify
Mhm.
phase 1, 2, and 4. We had them do almost daily ovulation kits when coming up to predicted ovulation.
Mhm.
And even with that, when we then went to analyze the retrospective blood data, we still managed to miss phase 2 in 10 out of 11 athletes. Like even with doing
Mhm.
as much as we could, they'd done a daily questionnaire, daily ovulation, we turns
Mhm.
out we hadn't actually got the surge in estrogen because it's such a short window. So we were like, yeah, on reflection, we were like have all this good data, but it doesn't quite fit into that phase. So therefore we can't actually use that part. So then that led to the final study in my PhD, which is the one I referred to earlier. And in this study, I didn't try to put people into phases. I just had them
Mhm.
do, I basically had four live races on a virtual kind of platform. Um, so they all did a performance test basically every week for 4 weeks. And on the day of that, they'd get a blood sample. So I'd have their estrogen and progesterone. And instead of trying to put them into phases, I then just correlated changes in estrogen and progesterone versus their performance time. So obviously that's not as strong in terms of research design, it's correlation. But the reason I did that is because I kind of wanted to mitigate how much data we lost in the prior study by trying to put people into phases. So it's super nuanced. And I guess for me as well, I work with
Mhm.
athletes. Like when we realized we'd missed phase two, there's no way I'm getting them back. Like
Yeah.
that's not gonna happen. Um, so
Mhm.
that's why we took that approach with the final study. We just had these scheduled races. And then whatever the hormones were, they were. We still used that information definitely to try and identify phases, and we still were able to
Mhm.
give everybody a detailed classification, be it eumenoric, naturally menstruating with or without ovulation, but we just didn't use
Mhm.
phases as the independent variable. So I've done both
Yeah.
approaches. They obviously both have strengths and weaknesses. But yeah, that's how I've
Yeah.
approached it.
Great. Thank you.
Thanks, Stephanie. All right, up next we have Sarah Johnson, and then after I'll read Joshua Wooten's question.
Hi, I'm Sarah. I'm a postdoc in Scott's lab. My video is actually disabled, by the way, Hannah. My question was, so firstly, thanks for the guidelines. Really useful. My question was, do you have any advice for people who report a slightly different type of hormonal contraception? Um, and do you have any ideas of, are there any groupings that could make sense? Because what I'm finding in my data is like I collect all this information and then they're all slightly different. And so then I end up with like two people in this group, two people in that group. And do you have any advice regarding what to do when you have those labels with those data?
Yeah, again, that's a problem I came across. So one of my studies, I was only interested in contraceptive users, and initially we're like, yeah, we'll recruit everybody on the exact same contraceptive pill, for example. But then after a while, I was like, I'm gonna have N of one. Like, this isn't gonna work. So then I guess we broadened it out in terms of the grouping there. So we only had people on the combined contraceptive pill with a monophasic delivery, and we grouped them all together, even if the specific formulation of the pill was slightly different. So we ended up with all different brands, but as long as the brand had that delivery, that phasic delivery, and was still a combined pill, then we included them. So we didn't have anyone on progesterone only or anyone on like an implant or a injection, IUD, that sort of thing. So yeah, I guess it depends obviously on your study, of course. But you could probably, yeah, maybe group those combined contraceptive users. Maybe you could group progesterone only. I guess another thing to consider would be systemic versus localized. They could maybe be groups. So obviously when you're taking a pill, that's a systemic delivery of hormones. Whereas if you have something like an intrauterine system, that's more of a local delivery of progesterone only. Maybe they can be grouped together. Um, yeah, I hope that answers your question, but I definitely came across that as well.
Yeah, no, it sounds like the logic is similar to what I'm thinking about. So
Okay,
great, thanks.
awesome.
Super practical questions here. I'm gonna ask this question from Joshua Wooten. We're currently conducting observational-based studies with team sports. What recommendations do you have for collecting menstrual cycle data to reach bronze or even ovulation to reach silver? Using a calendar seems unrealistic for more than 50 athletes, which I think you touched a little bit on in your presentation.
Yeah, I guess I feel like in terms of, I guess I have a question for the question. I don't know if we can go back, but I'm just thinking what part of the calendar would be kind of the challenge, I guess, because I guess in terms of the calendar counting, all we're asking the individual to do is every day they basically just record whether they're bleeding or not bleeding, and then we can get that cycle information from there. So there's lots of different ways that you can do it. Like some athletes like to use apps. You can literally use pen or paper. Like there's doesn't need to be fancy. Um, but it's not something, yeah, I feel like that's quite the entry level. Like the participant just records that every day. Like for example, in studies, I've just had a little kind of Google form they just submit every day. Like for some athletes, it's part of daily monitoring, so they'll enter their wellness questions, and then there's just a quick yes, no, are you bleeding? Are you not bleeding? And that just helps us to identify the real basics in terms of like cycle length, cycle regularity, identify any early flags there. So that would, I guess, be my first approach for that kind of team-based environment when you've got a large number of athletes. Because yeah, that's definitely going to be, we're not going to be able to get super detailed measures every single day. And also we want to think about athlete compliance as well in terms of that. So for me, something I always try and do is educate the athletes around what data I'm collecting before we start. And then once we're done with data collection, I'll always provide them some sort of education and results so that they can see what I've done with the data. Because I find that once they know it's actually being used and what we're doing with it, I found compliance much better rather than just please complete this data, it goes into a black box type thing. So I guess, yeah, that would be the entry kind of level for that team sport if you get that calendar counting. And then perhaps if you were interested in ovulation, you could introduce that, but that's obviously an additional cost and resource. But I mean, it gives great info. So yeah, I hope that's somewhat answered the question. Please let me know if it didn't.
Okay, thanks. Yeah, Joshua, feel free to add more. Oh, he says, okay, that helps and is close to what we're currently doing. Always curious how others might be doing it. Thank you for your work.
Awesome.
Awesome. All right, and next up we have Louise Burke on camera, ready to ask her question. Feel free to introduce yourself, Louise.
Hi, Ella. I'm Louise Burke from Australian Catholic University. You may have heard of me. And and I'm asking this all the way from New York City. So fantastic presentation, but I knew you'd knock it out of the park because you were such a wonderful PhD student and love continuing to collaborate. So here's my question. You said at the beginning that you were really cranky or frustrated that not much research had been done with female participants in sports science. And so you took that on as a young researcher. What would you sum up as sort of the challenges and the benefits of doing this type of research? And if you were trying to guide a young researcher now from thinking about jumping into the whole research mode with female athletes, what would your advice be?
That's a good question. Thank you. I mean, I guess that kind of outlines why we made these resources, right? Like we kind of did the trial and error and we tried to implement the best practice guidelines. I guess when I started my PhD, I was like, every single one of my studies are going to be gold standard, like the perfect methods. But then you try and do it and it just doesn't quite work for whatever reason, which I guess kind of underlies why we made those resources. So I guess we have the flow chart where you can go through and have a look and kind of make your decision as you're going through and understand the implications. But in terms of young researchers, like I would still say absolutely we need more researchers in this area. And I absolutely loved it despite how challenging it was. Found it super rewarding. Like I found the participants were really happy to be engaged in research. And we actually did a study. We asked, sorry, everybody kind of an exit survey after they completed each one of our PhD studies in terms of how they found the experience. Because obviously we want to complete more research in women, but we need people to actually volunteer to do it. So we wanted to see how the experience had been for them and if we could make it any better. And yeah, we found that I think it was about 90% hadn't ever completed research before, and the majority of them was just because they didn't have any opportunities, not because they were unwilling. They just nothing had presented themselves to them that they were able to do. And then I think I can't remember the exact number, but it was in the high 80s or 90s said that they would be happy to do research again, even after we'd implemented at least silver tier for all of them. So more resource intensive. And I guess I know I can be guilty of saying, oh, I won't find anyone that wants to track their cycle like this or measure ovulation every day. But we actually found lots of people that were happy and willing to do it. So that was a super positive experience from that. And I guess, yeah, that kind of underlies why we made those these tiering system and the tools that I presented today to make it a bit more accessible and easy and a bit less daunting when you read the paper of all these things you have to do. I guess this is kind of like an intermediate step of, okay, how do I actually do that and how do I apply it? I hope that answers
Fabulous.
the question, Louise.
Yes, absolutely.
And I love that you were finding that people were actually even willing to take part in the research in the way that you were surprised at.
Yeah, that was one of my favorite findings. Like it was just, yeah, it was so nice that people were, even though we applied a method that might be, it was more demanding than what we asked the men to do, for example. Like they were still still willing to come back and do it again. So that was really encouraging.
Awesome. And I like, yeah, sharing the research too. Speaking of sharing research, we've got Trent Stellingworth, who's going to ask him his question.
Hi, Ella. Great to connect again. And of course, I was one of the external people on your committee. For those that don't know me, I'm Trent Stellingworth. I'm the Research and Development Director at the Women's Health and Sport Performance Institute, WISP in Boston. That's also part of the Woodside Alliance, as well as up here at our Canadian Olympic Training Center. So I have a question more around the kind of more clinical or sport application of monitoring the menstrual cycle. And I would say I was definitely ignorant 5-10 years ago. And I would say, and I'm curious of your thoughts, if you had a naturally menstruating female, you would just check the box and say, yep, they're all okay, let's move on. And my eyes have been opened, I think yours have as well, around the fact that a woman may bleed every 14 plus or minus a few days, but that doesn't necessarily mean they're on track or healthy. So I'm curious as to what you feel about ovulation testing as a tool to just check, and how many elite athletes might naturally menstruate and be anovulatory, and whether and when and where urinary ovulation testing in athletes is worthwhile as just a clinical check to make sure things are progressing and that athlete's healthy.
Yeah, for sure. Thank you for the question, Trent. And yeah, thank you for jumping on today. I think, yeah, that's such an important point and one that the research has really opened my eyes to. Because, yeah, it's super easy to think, right, yeah, bleeding every this many days, we're all good. But there's so many other things, especially those that are asymptomatic. So you pretty much are going to be unaware if you're ovulating or not without actually measuring it, which comes back to Kirsty's measure, don't guess, which I love. So, I mean, I would absolutely advocate for ovulation testing where practical and feasible. Obviously, it's completely not feasible for me to go into work in a second and make all the female athletes at work start taking an ovulation test. I would definitely take a more individualized approach. And something I've learned when moving into practice is that this is just kind of one part of my toolbox. When I have a female athlete, it's just one part that isn't in there for males, if that makes sense. So it's just something else that I consider. If I have an athlete come to me, oh, I'm really struggling, I'm tired at training, it's just something I'll think about. I think that's been a bit of a transition. When I started my PhD, it was probably the first thing and the only thing I would have thought about. So it's now just part of my toolbox. But in terms of ovulation specifically, I'd be fairly confident it's higher prevalence of anovulation than we necessarily think at the moment or have evidence for. I'm trying to think of the exact numbers, but again, all my studies have measured ovulation. So I think it was the final study. We had roughly 40 athletes. I think we had 2 of those that didn't ovulate in any of the cycles. But what I found even more interesting, I think there was 5 or 6 of them that ovulated in one cycle, but not the next. And again, I found that fascinating, like for 2 reasons. One, if I just measured one cycle, I either would have classified them as ovulating or good or not ovulating. So that's the first reason why we always have those 2 cycles. But secondly, just that variability between cycles. Like, who knows if I'd measured that for 12 months, was that one ovulatory cycle the anomaly? Did they actually not ovulate for the other 11? Or was the anovulatory one the anomaly and they did ovulate for the rest of them? So there's just so many kind of different variations and nuance in that. So yeah, I would completely advocate for it for sure. And yeah, I hope that answers your question, Trent.
Yeah, it's kind of nuts that in this day and age we still don't know the anovulation prevalence rate in our female athletes. If they were NFL football players, they would have had that sorted out 20 years ago. So always work to do in this space, and thank you for your contributions and a great talk today.
Thank you, Trent.
Thanks, Trent. That's a great mission.
Yeah.
Call to action.
Yeah, if anyone wants to do that study, please let me know.
Um, Ella, I think we have time for just one last question, so I'll put it in the chat. It was how should prior research that did not consider effective hormones, for example, menstrual cycle or oral contraceptives, be interpreted? How can we use this to sort of interpret what's been done before?
Yeah, for sure. So a lot of what I did at the very start of my PhD was looking at the existing research and just trying, yeah, to understand what we already have. And I guess that kind of underlies my transparent reporting message that I've been going on about today. Because the main thing that I found when looking at the historical papers was just the lack of reporting. Like I just didn't know what they did. Some studies didn't even report the sex of the participants, like which was just mind blowing. Like it was just we did this many humans. So I was like, I can't even like it wasn't a lot, but there was definitely more than I expected that were like that. Um, so yeah, sorry, I feel like I've forgotten the actual point of the question.
How to interpret, I guess, when
Yeah,
we
sorry.
the sex of the yeah, go ahead.
Yeah, I got distracted. Yeah, no, I would be using that checklist that I provided at the end to kind of, that's exactly what I did. I would get out the methods section of the paper, go through the checklist, what information do they have? If nothing, then I'd still read the paper, still understand the study findings, but just have the nuance in the back of my head. Okay, if I have maybe a female athlete who's anovulatory or eumenoric, would this finding apply to her? And can I think of a reason why it would or wouldn't? Like, I guess we can't just assume that nothing's going to apply to women because we haven't done that specific study, but it's using kind of our evidence base and our knowledge to kind of problem solve and work it out. So I'm sure a lot of the research we've done in males is applicable to women. I don't think we need to redo the entire evidence base. I think it's just having the common sense in applying that. And something I do really use that tiering system to sort of understand the level of detail in a study, which then helps me inform how I apply and interpret. Yeah, that was a great question.
Sure. Yeah, and it's your system is such a nice objective way to just weight, like you're saying, the knowledge that you're reading and yeah, integrate it into your practice that way. So thank you so much, Ella. It's so practical, so useful. I think we just have a couple last slides to share before we close out.
Yes.
Thank you for answering the Q&A so well, and thank you all for participating and sharing your questions. That was awesome. We hope to do more of these. And so one way that we can do that is to have nice feedback from this one. So this is our inaugural event. We really thank you for attending the Female Athlete Research Forum, our first one. Please complete the survey that will appear in your browser window upon the end of this webinar so that we can keep doing this. And we'd like to just acknowledge that this was supported by the WUSI Human Performance Alliance, which is funded by the Joe and Clara Tsai Foundation. So thank you all for the ways that you're elevating health and performance for female athletes. And really huge round of applause and thank you to Dr. Ella Smith and our awesome tech team who managed the webinar today. With that, we'll close out and hope everyone has a very happy rest of their day.